Alright, so here we go. It's week 5, winter 2020. It's dermatology. Actinic keratosis is what we're talking about today. Don't want to miss this one because this is pre-squamous cell carcinoma. There's AKAs. Actually, an AKA is AK. Solar keratosis, sometimes it's called. Senile keratosis. Sometimes they just call it one of the keratoses, but they shouldn't. Remember, we talked about seborrheic keratosis last time, and that's not cancerous or precancerous even. This one's precancerous, so it's not good to just say keratosis. And plus, it's best to call it actinic keratosis instead of solar keratosis, because if you call it solar keratosis, then you might call it SK. And SK is reserved for seborrheic keratosis, so be careful with that. If you do call it solar keratosis, don't ever call it SK. Here's kind of what it looks like. The key is to look for a little yellow crust on it, as we'll see here. But again, it is a precursor of squamous cell carcinoma. It is super common, one of the most frequently encountered skin lesions on the planet. And histologically speaking, it's a dysplasia. It's a tissue that's become dysplasia. Specifically, the keratinocytes have mutated, and really it's the basal cell that gives rise to the keratinocyte has something wrong, and it's creating keratinocytes that are mutated. But the basal cell looks fine, because remember, the basal cell makes a copy of itself, and then it makes a keratinocyte, and the keratinocyte is mutated. It has a really large, really way too big. It's weirdly shaped. It's hyperchromatic, so it's got a lot of dark granules in it. And yeah, it is a dysplastic cell. The key, though, is that none of these dysplastic cells show up in the dermis. Okay? If they have invaded the dermis, you got squamous cell carcinoma. But if they have not invaded the dermis, then it's still actinic keratosis. And a lot of times these things have to be sampled. There are 3 different categories of these things, histologically speaking. Category 1 is the best type of dysplasia. It's confined to the bottom third of the epidermis. So, I mean, if this is the top of your skin up here, this is the stratum basale, the bottom layer. This is the dermis down here. So the dysplastic cells will be in this 1/3 right here. Here's the sunshine up here. There's Mr. Sun. All right, if it's category 2, that means that the histologist sees that the cells have invaded the top 2/3. If it's category 3, that's the worst. The lesion is throughout the entire skin, but it still has not gotten down to the bottom. If it gets down into here, it's cancer, squamous cell carcinoma. Regression. Interestingly, category 1, even though they pop up and they look a little scary, they can disappear completely. So in fact, about 25% of them, the category 1s, will completely disappear within a year. Category 2 and 3, they don't have a very good chance. Category 3's chance is not the greatest, or category 2's chance is not the greatest. Category 3, it's probably not going to ever go away. Get it removed. Risk factors. Sound like a broken record here, but it's cumulative exposure to UV radiation. So it's how much sunbathing you did when you were a young person, how much tanning bed exposure you had. Those tanning beds, no matter what the ads say, those things are not good for your skin. And the lesions are found on, so therefore the lesions are commonly found on sun-exposed surfaces, like your nose, top of your nose, or places you forget to put sunblock, the tops of your ears, the pinna of your ears, etc., the shoulders. And that's where that aka solar keratosis comes in. which ones become cancerous? It's really hard to predict which ones are going to, of these actinic keratotic lesions, are going to actually turn into cancer. But there's three. This is definitely, I should have like stars all over. There's three risky types of these lesions that you definitely need to see a dermatologist. If they're tender to the touch, they shouldn't be painful. That's not good. If they're really thick and crusty, that's not good. And if they start oozing any type of juice, that's not good. So these are the danger signs that it's either become cancer or it's on its way to becoming cancer. How does it present? So it's a kind of irregularly shaped macule. So but it's a weird macule. It usually has crusts on top of it. So the macule can be red in color, but the key for me is it's got flakes or little scales or a crust. Probably it's best to call it scales, but sometimes it looks like a crust. Scales are more scaly looking, and a crust is just more crusty looking, like the crust of a pie that you rough up a little bit. But these yellow to white scales are the key. So you have a kind of a red erythemic macule, and then it has a little crust on top of it. We'll look at a bunch of these things in a minute. Actually, I should have had one in there. Let's look at one right now. So here we go. So there is a macule, less than a centimeter, and it is red, erythemic, and then it has a crust on it. See, that has scales on it. It has these yellow-white scales, and there's one over here. So that's classic, run-of-the-mill actinic keratosis. There's actually three types of these things. We'll talk about a couple of them. But there's hyperkeratotic actinic keratosis, pigmented AK, lichenoid AK, and atrophic AK. But the classic one, as we said already, it's an erythemic macule covered with yellow scales. But you have to be careful because sometimes they don't have these. And we'll look at plenty of these pictures right now here. So here, this is also AK, and it doesn't look like the classic type with it because I don't see any scales, do you? Maybe a tiny little, kind of a red-looking one right here. This looks awful lot like a port wine stain or Nevius flammeus, and it's tough to tell apart. You're going to have to take a little histological sample of that to make sure that is so. This is actually the pigmented type of actinic keratosis, and this just looks like blush on somebody. So they can be a little sneaky, but they're usually not. They usually have that yellow crust on them. So what's the chances of your actinic keratotic lesion turning into squamous cell carcinoma? It's about 10% of these actinic keratotic lesions will transform over a 10-year period. So that's kind of the 10 on 10 rule. So I mean, it happens, but I don't want to say it's rare, but it's not common for it to transfer. And remember that mutated keratinocytes have to dig through the basal cell membrane, or the basement membrane, to get into the dermis, and then their diagnosis of squamous cell carcinoma. In a lifetime, it's about 18-20% of these will turn into squamous cell. You do have to keep a close eye on them. So here's someone severely, and this is not normal, but this is someone severely affected with these. So these are actinic keratotic lesions everywhere. She also has one that's turned cancerous out of all this. Can you see it? Well, actinic keratosis should never have a nodule in it. If you ever see a nodule on one of these lesions, they have to go to the dermatologist. So there's the nodule. There's one there. Can you see it there? And there's one right there. Yeah, so those were flat out cancer, so those had to be surgically removed. Hypertrophic actinic keratosis. This also has the usual presentation with the yellow-white scales in the base, the classic look. But the difference is the scales get crazy thick. This one must be biopsied because this one has remember, this is one of the risk factors if they get thick. So that has to be biopsied because the chances of it becoming full-blown cancer are much higher. These are one of the three risk factors. So here's a perfect example. Look at how those scales have coalesced together and have formed a clump here. Now you have to be careful because seborrheic keratosis can get crusty looking as well, even a yellowish crust. But it would never look like this. So that is really, really way too thick, and that did turn out to be squamous cell carcinoma. Here are some other ones where you can see the scales, the flakes. They're more white in this picture. Could be the way the picture is exposed to, but white to yellow, crusty, scaly lesions on an erythemic base is classic actinic keratosis. This is also hypertrophic keratosis. So those need to be biopsied. Little molecular biology. We do know who the mutation is. It's the TP53 gene mutation that is strongly associated with it. This particular gene, which lives in keratinocytes and lives in the basal cell that creates the keratinocytes too, it is mutated by UV damage. The gene product is of the TP53 is tumor protein P53. And what does it do? It's a cancer snuffer outer. It looks for cancer cells and destroys them. So it's very important for stopping these cancerous cells. Specifically, it snuffs them out. It stops them from dividing super fast, and it can slow them down. It can destroy them as well. But it's a tumor suppressor gene. So we have those all over our body. We need those. So it's not good to have these out of action because some mutation wrecked them. Let's look at some more pictures. So here's one again, a macule with erythemic red in color. You can see flakes of yellow within it and white within it. So this is actinic keratosis. Here's another one, and again the camera skin exposure is important, but a crusty, kind of scaly top, an erythemic base. That's not good. That always goes to the dermatologist. But sometimes they're really hard to tell apart from squamous cell carcinoma. Maybe it looks innocent, it's not thick, it's not painful, it's not juicy, and it looks innocent, and it turned out to be squamous cell carcinoma. So you can't tell. It can look just like the great imitator, seborrheic keratosis. And it can also look like something called atypical lentigo maligna. So it can be hard to say. So there's no question about this. This is a really, this might even be a dermatological scope where it's greatly magnified, but you can clearly see the scales on the lesion on an erythemic base. So this is actinic keratosis. Actinic keratosis. All right, risk factors. Well, if the sun causes it, anything that gets you out in the sun, so sailors, farmers, tennis players, golfers, outdoor enthusiasts, deep sea fishermen, all have a much higher rate of squamous cell carcinoma than the normal human. How do you manage these things after you get a biopsy and it comes back? Well, it's not cancer, we'll just keep an eye on it. You have the option to get rid of it if you want. I mean, you can do laser surgery and burn it off there. There's facial peels that really don't work, and they're on the YouTube, and their own studies show about a 7% success rate, and those are the industry studies, so I wouldn't recommend those. You can use keratage, but it bleeds a lot, so a dermatologist can scrape it off, because remember, it's not into the dermis. The trouble with it, it may come back again because it's the basal cells, the stem cells below, are making it. You can try good old retinoids. Diclofenac gel can be tried. But the smartest thing to make them stop them coming back is avoid the skin or avoid the sun, and use a really strong sunscreen that has UVA and UVB in it. All right, let's see if you've learned anything. Well, that's an easy one. Red erythemic lesion with yellow crust, AK, actinic keratosis. How about this one? Well, it looks like AK again. I mean, there's a crust, but look at the crust. It's a little deeper looking. I mean, that's hard to tell what it is, but you want to get that. Because basal cell carcinoma, it can start to look like basal cell carcinoma as well. That turned out to be squamous cell carcinoma. Okay, that's just flakes, yellow scales. But this is all precancerous. That's actinic keratosis. See, that's another one. You can't see it, but it's raised. It's almost starting to look a little ulcerated. That did turn out to be squamous cell carcinoma. It almost starting to look a little like basal cell carcinoma, which we'll talk about. Basal cell is very destructive. It doesn't metastasize as much, but it's very, very destructive. What about that? Well, that doesn't look like anything we've been talking about. That's completely flat. I don't see any kind of crust or scales on it. And that's just a go to a lentigo lesion. Kind of like well, not like a freckle, but it's akin to a freckle. We talked about that. How about this one? Really waxy looking. We talked about these. So that's a seborrheic keratosis lesion. Kind of not the typical appearance, but they do get waxy looking. How about that? Oh, that's really crusty looking on an erythemic base. That's actinic keratosis. That's an easy one. How about that? Well, that's no crust, right? It's not yellow. There's no erythemic base. That is just a lentigo lesion. And we'll show you the difference between that and moles as well. We'll get to nevus. Well, there's a warty looking thing. That's easy. That's seborrheic keratosis. But it's not scaly. It's more warty or kind of cobblestone appearance. So that's seborrheic keratosis. It's not cancerous. All right, let's talk about the actual squamous cell carcinoma here. So again, SCC is a common abbreviation for this. This one arises from, again, these mutated keratinocytes that were created by the basal cells. It's really, they're not basal cells. Again, basal cells are the stem cells that create keratinocytes. But when they create a cell, they split by mitosis and they create a fresh new basal cell. It's not a proliferation of basal cells. That would be basal cell carcinoma, but it's really still the basal cell that's mutated. Nevertheless, the authors say that these are mutated keratinocytes, and they are. It's an overabundance of keratinocytes. And they grow rapidly. They have grown so much that they've become immortal too, right? Forgot to mention that, but cancer cells become immortal. So they usually the cell cycle of a keratinocyte is 24 days, and these things can be permanent. They don't die. So mutated, they've breached the basement membrane and they're into the dermis. So of all the skin cancers, your chance, if you have a skin cancer, about 20% of the pie. It's the second most common type of skin cancer. Basal cell is by far the most common. The incidence is on the rise. Some think it's maybe the ozone thinning. We're not sure what the deal is, but there's kind of an atypical one. It's kind of a weird looking crust on it. There's the red base on it. The key is that red erythemic base, but it's a nodule. See how it's raised, so that's no good. Lifetime risk for a white person, a Caucasian, is about 10%. Darker your skin, the less chance, because the better you are at resisting UV radiation. They present as macules. They can be eroded macule, and nodules you got to watch out for. When they have an ulcer in them, it's really hard to tell these apart from basal cell carcinoma. They can look plaque-like, so there's quite a few varieties to the presentation. They have different textures, different colors. Sometimes it's really tough to tell them apart from just run-of-the-mill actinic keratosis. It is, however, it can look like actinic keratosis with a nodule in it. So that's kind of a dead giveaway. And yep, and they, as we said, they can come from their precursor, which is actinic keratosis. So here's one. I mean, it looks kind of innocent, but the key is you can't see it, it's a two-dimensional picture, but it's coming out of the plane of the page. So it's formed a nodule here, so that's no good. That's SCC. Risk factor, again, is the same for actinic keratosis. It's UV radiation exposure. In fact, they've done studies. The closer you live to the equator, the greater your chances of developing squamous cell carcinoma. For every 10 degrees that you get closer to the equator, the risk doubles. So people who live at the equator, especially white people, have to be very, very careful of the sun. The number of prior sunburns, has been research on how many times you've been sunburned, and sun exposure, that's directly related to the development of these as well. And they show up the same place, sun-exposed areas. 75% of these things show up on the head or the neck. So that's the favorite place for these. Again, on the ears, any place that gets exposed and you forget to put sunblock on them. And, yep. Typically more aggressive when they're found in the head and neck region as well. We've looked at that one before, but there it is again. It's coming a little bit out of the plane of the page, so it's a little more raised than it should be. It looks awful lot like actinic keratosis, so if it was perfectly flat and scaly, but it looks like it might have been oozing a little as well. The mean age, so this is more of an older person disease. 72 is the average age to get these things. The aggressiveness and the age develop directly proportionally, so the older you are, the more likely it is to be aggressive because the weaker your immune system is for it. Males seem to be at greater risk than females. And these things, so basal cell, with regard to metastasis, I can tell you right now, basal cell carcinoma doesn't tend to metastasize as aggressively. Squamous cell carcinoma can definitely metastasize, and that'll kill you, right? And once it gets in and it goes to the heart or lungs or brain or spine, it can fly all over the body, and you'll die from that. Malignant melanoma is incredibly, its ability to get inside the lymph system and the microcirculation is incredible. That's the most dangerous. So the worst is malignant melanoma with regard to metastasis, then squamous cell carcinoma, then basal cell carcinoma. Good, nice board stuff there. Two risky groups are the outdoor enthusiasts, sunbathers, the ones who've been exposed to the sun. There is another group that's at risk for developing these. So these are the cancer who've had other types of cancer. So radiation exposure for treating the cancers and things like that. There are some people at really high risk for not like you're going to get it for sure, but much higher risk than normal humans. If you have red hair and light eyes, green or blue eyes, and you have a lot of freckles, you are at risk for these things. So hazel eyes, any kind of off-color eye. Previous use of PUVA therapy, that uses a radioactive tracer, sorulin, has to be injected. I would never do that to myself because of that. It does increase the risk for cancer. It's used to clear lesions, other types of lesions like seborrheic keratosis and things like that, and eczema, some other the eczematous diseases. There are people who've had the HPV virus, the genital wart virus, human papilloma virus. They're at risk for this. We don't quite understand why that is. People have used chemical peels, radiation exposure, we already said. Actinic keratosis, we just did a whole series lecture on that. And that's a very common, about 18% in this Hamblin studies found 18% of actinic keratosis. Patients morphed, it morphed into squamous cell carcinoma. I think that was a 20-year follow-up on that one. Immunosuppressed patients are very vulnerable to this one. If you've had an organ transplant and you have to be on immunosuppressants, you have got to use sunblock like crazy. Your risk of developing squamous cell carcinoma increases by 65-fold. That is crazy high. The number one target is the scalp, the back of the hands, and the pinna, this rim here of the ear where you may forget to put sunblock. So this one's down a little bit, but you can tell that's a nodule that's grown there, right? And it's still got a little yellow-white crust in it. So that is, someone's waited way too long. That could have been caught much earlier. Hopefully it hasn't metastasized. There's another one. This looks really similar to basal cell carcinoma. Basal cell carcinoma likes to ulcerate, but there's a nodule here instead. Erythemic base, but it's not white or yellow. It can look different. It turned out to be squamous cell carcinoma. There's classic squamous cell carcinoma with a yellow crust, which is raised up. It's hard to see in this picture, but it's thick, raised up. Classic squamous cell carcinoma. That's really raised up, right? That again to me looks like it could be basal cell carcinoma. So sometimes even the dermatologists don't know. You just have to get it biopsied to see. It's definitely not good when you have a raised lesion like that. Here's another one that looked like it could have been actinic keratosis at one time, but the biopsy turned out to be squamous cell carcinoma. Another one on the back of the hand. So yeah, these are raised up. There's actinic keratosis all over the place. This is all precancer, but this is obviously turned into a lesion, and that's squamous cell carcinoma. What do you do for treatment? Surgical removal is the gold standard. You have to take wide margins around it and you cut it out of there. You can try to freeze it off if it's on your face. If you're worried about your looks, I wouldn't hesitate. I wouldn't mess around with any of this stuff. You need to get that out of you, in my opinion. Okay, let's shift gears. We talked a little about lentigo, those flat brown lesions. So there is a precancerous form of lentigo, and that's called lentigo maligna. In fact, when lentigo maligna, the precancerous form of lentigo, when it becomes cancerous, you call it lentigo malignant melanoma. So it's a different kind of story. Let's talk it over. So sometimes it's called melanoma in situ or Hutchinson's melanic freckle. Hutchinson's freckle is a common word for it as well. So this is the precursor to the dreaded, highly metastasizable malignant melanoma. And yep, so it's a precursor of lentigo malignant melanoma. So when malignant melanoma, which we will talk about, when it comes from a precursor form, when it comes from lentigo maligna, you call it lentigo malignant melanoma, or LMM. So again, the same story as the other ones. There's a history of severe sun damage. So people have had many burns on the area, so therefore it shows up on burned areas, your face, your neck, things like that. Now the good thing about this precancer is it's very, very slow growing. But once it becomes cancerous, it can take off like lightning. But this precancer phase, if it comes from a lentiginous lesion, it's a good thing because it grows really, really slow. In fact, it happens in older people. Many times they die of other causes before this even becomes cancerous, and they don't even worry about it. They just monitor it. It's called carcinoma in situ phase of lentigo malignant melanoma by some authors. And yeah. So, and you could also say that it can spread. It can get really, really take over the skin, but it has a really extensive horizontal growth phase, which means, let's go back to my wonderful skin drawing, stratum basale, stratum corneum. Here's the dermis down here. Here's the outside world. There's the sun. So it starts growing, and instead of immediately growing down into the dermis and becoming cancer, it tends to just take over the skin and grow this way. And grow. You're going to see some huge lesions. That's the horizontal growth phase. So it may never, the vertical growth phase, when it grows down, that's really dangerous. So this one can really take up a lot of area, but it can stay a precancer for a long time. Sorry about my voice. And it is a neoplasm of melanocytes. So these are mutated melanocytes for the first time. We haven't talked about those yet. Remember, the melanocytes are the ones that inject adjacent keratinocytes with melanin, and they shield the nucleus with a kind of a nuclear cap. But the most ironic thing is they don't shield themselves, and therefore they're susceptible to damage. At least they're deep in the dermis. They're protected by all the layers of skin. But it's really strange. I don't know why the committee didn't stick one tentacle back in itself and shield itself. So it's really quite strange. But it is a tumor of mutated melanocytes which become immortal. They haven't reached the dysplastic phase because they haven't penetrated the dermis. You could also say they have not entered that vertical growth phase yet. They usually happen they can happen de novo, so they may not show up from a lentigo lesion. Here's a lentigo lesion. Looks like there's a little makeup on that. But some of them morph into lentigo maligna. Some lentigo lesions morph into lentigo maligna. Some of them just pop up without any precursor and they're lentigo maligna, so they don't have to do that. That means they start de novo. And then years later they become cancerous. About 90% of these lesions are on the face, head, or neck somewhere. So you don't see them below the level of the neck very often, about 10% of the time. If you do, it's probably going to be on the back of the hands. Prognosis is good because of that slow horizontal growth phase, as we explained. But once it enters the vertical growth phase and digs into the dermis, now you got yourself melanoma, and melanoma, those cells can penetrate the lymph capillary and just the regular capillary really easily. They love to spread. One study done here in Habif was when diagnosed at the age of 45. In this study, only 3% of them, when the patient was diagnosed with lentigo maligna, only 3.3% of them progressed into lentigo maligna melanoma by the age of 75. So they can stay in this phase for your whole life. Lifetime risk's about 5% for these things. Here's the natural history of them. So they start out kind of as a smaller, flat, brown lesion, but they spread vertically, or they spread horizontally. So you have this phase here. They can start to get a little variegated looking. There's areas of regression too in these things we didn't mention. And then years later they can start getting nodules in them, and that's a bad sign. When the nodules start popping up, it's probably become cancerous. That's kind of the natural history. So let's talk about cancer, lentigo malignant melanoma now. So this is usually presents about the age of 65. 90% of these lesions are on the face, 10% are in other areas. So just like lentigo maligna, they typically come from lentigo maligna, or the Hutchinson's freckle usually turns into these things. And on average it takes about 13 years for them to become cancerous, according to this Habif. About 10% of all melanomas are this type, because there's many different types of, like subungual melanoma we'll talk about. That's the one that killed Bob Marley. This is lentigo maligna melanoma. There's different types of melanoma. Lentigo malignant melanoma usually means it's a melanoma that's on somewhere the neck or above. Risk factors besides skin, sun, I mean that's just a given. There is a gene, I'm not going to get into the weeds on this. There's a gene mutation on chromosome 10 that increases your chance for this. There has been some there is an increased risk for people on estrogen and progesterone therapy for menopause. There is some, not the greatest evidence, but I'll at least mention it. People who use red hair dye, it's not solid yet, but you should be careful with the red hair dye and maybe do more research on your own with that. I'm not going to go any further into that though. And of course, Caucasians, because they don't have much melanin to begin with, so the melanocytes are more prone to injury. It's easier for UV to get through a white person's skin than a person of color skin. And we know that all people's melanocytes aren't protected. So what's the difference? How do you tell between lentigo maligna and lentigo malignant melanoma? That's a very important thing. So lentigo malignant patients, I look at variegation, and they're not strongly variegated. People with lentigo malignant melanoma are deeply variegated. They have black in the lesion and light brown and absent normal skin color. The lesion is strikingly variegated, where lentigo malignant is not, and we'll see pictures of this here in a second. Also nodules. Lentigo malignant patients don't have nodules. If you have a nodule, it's probably turned cancerous, and that's not a good sign. Okay, so this is lentigo maligna, and talk about that slow horizontal growth phase. Look, it's taken over almost her entire forehead here. But there are no nodules, and it's very lightly variegated. I mean, here's a patch in the middle that's almost back to normal. There's a normal spot here, but then it's dark. But it's not black here and light here. The variegation is not really coarse. But this is classic lentigo maligna, not lentigo malignant melanoma. Now, this person, really dark brown here. I mean, it's almost skin color here. Lighter brown here. Different shades of brownness. Plus, it's hard to see, but there's a little nodule that started right there. But even if you didn't see this nodule, I'd think, oh man, that is cancer. That is lentigo malignant melanoma. That's melanoma of the face. Dude, you need to get that taken care of. Waited way too long, right? Why did they come in? Why did they wait so long? Well, I would say that's lentigo maligna because it is not really, there's nothing raised on it. And it's not, I mean, it's a little dark here, but it's not like that, right? That's lentigo malignant melanoma. So that's just lentigo maligna. Here's another one. Well, again, it's not, I mean, it's a little dark here, but there's no nodules. That turned out to be lentigo maligna. Yeah, if you miss this one, I put this on the test. People miss this one, you fail the course. I'm just kidding, but you should fail the course. This is horrible. This guy waited. I mean, it's metastasized. So huge nodules, right? Course there. Look at the difference. Black, almost completely black here. There's an area of normal color here. Huge nodule here. That's lentigo. That's melanoma of the face. Lentigo malignant melanoma. What do you do for these? You got to take it out. It's got to be surgically cut out. And I mean, that's going to leave a huge hole in your face. So sometimes the patients, you have to use radiation therapy instead, and chemotherapy, things like that, because you just can't take the whole patient's face off. I guess we could. Well, no, you can't. So it can get, that's why you got to see a dermatologist. You know, when in doubt, catch these things early so it doesn't get so crazy, because the excision, their very wide margins have to be taken to make sure you got it all. So huge cosmetic problems. Second best is radiation therapy. So pretty good support. It supposedly has a 93% success rate because the tumor's not hiding inside the lung or the liver. It's right there, so you can really blast it. So here's another example. Here's an 82-year-old man with obvious lentigo malignant melanoma. Look at how dark that is, and completely skin color here. No real nodules in this case, but he had the radiation therapy, and 3 months later, pretty much gone. Left a little erythema there, but so it does work. All right, thanks for watching. Let's hope this came out. We're using the new PowerPoint on this one to see if maybe we can fix Boingo's problem. See you later.